I can tell you the perspective from home care, hospice, and VPA, because we kind of work as a Trinity team.
Yeah.
So pretty much the way it works for us is we get a referral from the doctor, and then we go out and see the patient, and we keep in really close communication with the doctor because we have to work under the orders of the doctor. And then we also do an interdisciplinary team conference basically every 14 days, so a couple times a month, in which we talk about our complete census, which right now is 65 patients. So we sit down as a team, and when I say team, it's registered nurses, LPNs, home health aide, physical therapists, occupational therapists, and speech therapists. And we all sit down and talk about the patient's care so that we're all on the same page. And then Hospice, Grace Hospice, which is a sister company of ours, comes to our meetings too with one representative. And so as we're talking about the patient, whether they're improving or declining, would they be an appropriate hospice candidate, that's when we're able to figure out where does this patient need to go on the continuum of care. What's really cool is that we can graduate a patient from home care, because our goal when we go in is to return them to their prior level of function. If they return to that prior level of function, they've markedly improved, we're able to discharge them. If they're not improving, then, they're declining, then we can pull in hospice. So it's really nice to have hospice, home care together along with the VPA, because you can take that patient forever. Mm-hmm. You know, whichever direction they're going in, you can take care of.
Yeah, especially since VPA is the doctor company, and then you've got hospice and home health as well.
Exactly.
And then how does the continuum of care actually work for someone like who works with it on a regular basis? Like, is it just the whole 485 process, or is there more to it?
Well, it all starts with the referral, which is a process in itself. And then once we admit the patient, then we get the orders from the doctor, which is the 485, which is basically synonymous for doctor's order. And then we carry out that plan of care, which is another name for the 485. So we follow that plan of care, and it's set up for 60 days. So within that plan of care, we're very patient goal-oriented. So we want to know from the patient, like, what is your goal? What do you want to accomplish with home care? What are we going to do for you? So it's always patient-centered care. And then as we progress toward the goals, or we don't, I mean, it's kind of, and you talk about the continuum of care, it's kind of like a linear, path. So you're either progressing towards the goals to where you can discharge, or you're declining and you're not meeting goals, so then you're going to look at hospice services, or then we can branch off into skilled nursing facilities, hospital care, there's so much. It depends, and every patient is different. So it's patient-specific care, which is we are a Medicare certified agency, so we have to work under the Medicare conditions of participation. And a lot of what that is patient-driven care, evidence-based practice, patient-driven care, and every patient you treat uniquely. So it's interesting.
It sounds like it. All right, and then how much care planning are you personally in charge of?
I am in charge of overseeing the care planning. The RN clinical in the field actually does what we call an OASIS, which is an outcomes assessment made by Medicare, CMS, the Centers for Medicare and Medicaid Services. They created this OASIS assessment, which is basically quantitative statistics that they're having our nurses collect for them. Okay. So it's like a 20-page tool, and Medicare is looking for certain things. They want to know what kind of home care patients are out there and how are they benefiting from home care. So this tool has to be filled out by the RN. So pretty much the OASIS tool is really the sole responsibility of one clinician. It can be a PT, it can be a speech therapist, or an RN. Those are the three people who can fill out an initial OASIS assessment. Now, OT can come into the picture and continue a patient, but they can't start a patient. Okay. That's a Medicare rule.
Okay.
So when they do that assessment, they're responsible for really looking at the patient as they are at that snapshot moment in time when they open the patient and really, saying, are they short of breath, are they not, are they in pain, are they not, and to what degree of pain. And then every problem that's identified at admission, we have to have an intervention for, and we have to address it, and we have to try to make it better, along with where the patient wants to go. So pretty much we try to return the patient to their prior level of function.
Okay.
And then my job is to get that document in my hand and make sure that it matches. It's a lot of questions. And so I got to make sure that if they're short of breath on page 3, they're still short of breath on page 4, and then everything makes sense for the patient. So that's my role in it.
Okay. Let's see. How do you determine what's necessary for like a pre-admission care planning?
Pre-admission care planning, it's a little different, in the hospital setting than it would be here in home care, because pretty much all we get pre-admission is an order from the doctor to say, we saw this patient and they had a UTI and you need to go out there and teach on their antibiotic. And then we get a med sheet from the doctor's office, a history and physical most of the time, and usually, since it's visiting physicians, they've seen the patient in the home, we get the record of their visit. So what we do before going out to the patient's home, we review all that paperwork that we receive in the referral packet from the doctor. We contact the patient and or family member, power of attorney, whoever we need to get a hold of to set up the admission. And sometimes prior to going out, there's questions, the family has, like, why do I need this, or what's happening, what does the doctor think? And we always have to work under doctor's orders, so we always have to say, this is something that your doctor referred you to us for this particular reason. Here's what we do. We come out, assess, we educate, we make sure you're not having adverse reactions to your medications, we make sure your infection is going to be resolved, or your wound is going to be healed, or whatever's going on with that patient. So that's kind of our pre-admission, is just that prior contact with the patient or family.
Okay. And then, say a person needs more care than that is initially planned, how do you determine payments and work with insurance companies?
We take certain kinds of insurance. We take all Medicare, some Medicaid, and then certain insurance plans. What we do when we receive a referral is it goes to our central intake department, and they determine whether we're a participating provider with that insurance plan. If we're not, then that referral will go to a home care agency, that is. So pretty much once we get the referral, the insurance stuff is all taken care of.
Okay.
Yeah. And then we are responsible to let the patient know if they have any co-payments for the home visits, or what their percentage of payment is. And normally, the majority of our patients are Medicare, and it's 100% covered.
Okay.
So, and we let them know that up front, because that's usually a concern. How much is this going to cost me? Yeah.
And then, let's see. How do you work around sudden issues such as a hospital-acquired infection received for planning care and providing services? So say, one of the patients ends up in the hospital, do you work with that hospital to know, what is going on, or is it all strictly through BPA?
No, it's definitely communication with the community hospitals, too. When we admit a patient, we do full body assessment, making sure that there are no wounds or things that we're going to find 2 weeks down the road because we didn't look in the beginning. So we always do that full body assessment, much like they do in a skilled nursing facility or when you go into a hospital. And so we can identify every problem that's there at the date of admission. If a patient develops decubitus ulcer, pressure ulcer, after we've had them, then, we have to take responsibility for that, basically. Just like the hospitals have to do now. If they develop a decubitus in the hospital, Medicare is not reimbursing hospitals for the care of that wound. So that's why it's so important that up front you know what's going on with your patient. So we really drive down those assessment skills right at the beginning. If we have a patient, which we do, one of our initiatives at home care is to keep people home. That's what we want to do. And we actually get judged on our outcomes and of the outcomes we get judged on is re-hospitalizations. So of course when we open a patient, if they're pretty sick, if they've got like an exacerbation of COPD or pneumonia or really fluctuating blood sugars, then we try to get out there like frequently, up what we call it is front loading the visits. So we're there 3 or 4 times a week to start to try to get them under control, because we don't want them to have to go back into the hospital with an infection or, bad blood sugar or hyperglycemia. So we really try to keep them home. But that doesn't always work.
No.
And we obviously do have patients that go back in. When one of our patients goes into the hospital, we're responsible to notify Medicare by making an OASIS, filling out a transfer OASIS document. That document tells Medicare our patient went into the hospital and here's why. With that said, too, we're then responsible to find out what facility they went to, notify that facility that this is our patient, fax them any information that they need on the patient, med list, most recent med list, most recent visit note, so that they have that information for continuity of care. And then once we make contact with the hospital and that discharge planner who's assigned to the patient when they're in there, then that discharge planner, when the patient's ready to be discharged, sends us their continuity of care upon discharge. And then we're required by Medicare, CMS, to go back out within 48 hours of that hospital discharge to create another OASIS document called the resumption of care. And then that again tells Medicare why they were in the hospital, what happened to them while they were in the hospital, what kind of procedures did they have, what were their inpatient diagnoses, and then now what's our main focus for home care. So it tells the story of the patient from home to the hospital to the nursing home, back to home. So it's, again, that whole continuum of care.
Thank you very much.